Next slide.
How do you know you whether they are not? Like how to respond to that?
Sir.
Good morning, all students. So we'll start today's class. The topic for today's class is Pseudomembranous Colitis, Ischemic Colitis, and benign tumors of colon. From the exam point of view, all these three topics are important. They can be asked as a short note question. So first we'll go with the pseudomembranous colitis. Slide. So coming to pseudomembranous colitis, it's an acute condition with the diarrhea, which is produced by the overgrowth of Clostridium difficile and production of its toxins, usually resulting after antibiotic therapy. Commonly seen after the usage of clindamycin and sometimes with other antibiotics also. And it is often seen in patients whose immunity is compromised and patients who are on chemotherapy for some cancers. The incidence is around 2%, with mortality is higher, around 30%. So what does it characterize the pseudomembranous colitis? The presence of an inflammatory pseudomembrane overlaying the intestinal mucosa is the one which produces pseudomembranous colitis. And this pseudomembrane consists of inflammatory and cellular debris, and it forms a distinctive patches of either yellow or gray exudate, thereby obscuring the mucosa underlying them. So this forms a membrane over the mucosa, obscuring the mucosa, and classically seen as a gray or yellowish distinct patch when we do a colonoscopy. So coming to diagnosis, before diagnosis, patient usually has a history of diarrhea, multiple episodes associated with sometimes pain, usually after following a antibiotic therapy, especially clindamycin, for a long time. So diagnosis wise, the specific diagnosis is stool cytotoxin assay for Clostridium, and ELISA test for toxins is also useful. Then colonoscopy is the ideal investigation, as right side involvement is more common in this scenario. So this pseudomembranous colitis can occur up to 6 weeks after stopping the medicine. So it will be, usually it is self-subsiding. As I told, the patients usually present with diarrhea, but sometimes they'll present in an acute condition with toxemia or perforation or hemorrhage. Treatment is usually with medicines. It's an antibiotic associated diarrhea. So the treatment again is by antibiotics. It is systemic antibiotics in the form of vancomycin or metronidazole, which has to be given every 8th hour for at least 5 to 7 days. So this is the treatment. Surgery is indicated only if the pseudomembranous colitis is very severe and involving most of the colon, producing either perforation or a severe hemorrhage. So otherwise it is usually a conservative management with IV antibiotics for few days. Next, moving on to ischemic colitis. So this is again an important condition which we usually encounter in patients, elderly patients who have got some comorbidities and admitted in critical care units for the management of other comorbidities or other acute conditions. So it's a local non-occlusive ischemia of colon, usually associated with small vessel disease, and uh, the colonic blood flow can be further compromised by alterations in the systemic perfusion. So that is one which produces the ischemia of the colon in the more susceptible sites, and that will produce ischemia and followed by colitis. So various spectrum from very mild form to a fulminant variety. So the first one is the reversible ischemic colopathy, which is associated with the submucosal or intramucosal hemorrhage. The second one in the list is the reversible or transient ischemic colitis. Then once the duration is a little longer, say for example 1 or 2 weeks, then it will go for chronic ischemic ulcerative colitis, which has to be differentiated from an acute ulcerative colitis, which is an inflammatory bowel disease. Then the fourth spectrum is the ischemic colonic stricture. Due to long-standing chronic ischemia, the muscularis layer becomes ischemic and ulcerated, and that results in colonic stricture. The fifth in the list is the colonic gangrene, when the patient presents with acute abdomen, with sometimes with perforation. And the last of the spectrum of ischemic colitis is the fulminant universal colitis, which is associated with a continuous massive bleeding through the rectum, and patient might end up in acute hemorrhagic shock, which requires an immediate intervention and stabilization in ICU. So in ischemic colitis, coming to the part affected commonly, any part of the bowel, especially the colon, can get affected by ischemia, but the splenic flexure is the one which is commonly affected due to its anatomical predisposition, because splenic flexure is the watershed area of the colon, receiving its blood supply from the terminal branches of the superior mesenteric and the inferior mesenteric arteries. So that's why it is called as watershed area of the colon. And there is what is called as Griffith's point, situated in the splenic flexure, that is called as watershed point. It is situated in the artery of Rheolin, where it gets poor perfusion by arterial disease, or because of the low perfusion pressure due to some shock, either because of pancreatitis or road traffic accident, burns, etc. And there is altered viscosity because of all these entities, and that causes ischemic colitis. So this is the point which is commonly involved in the ischemic, commonly involved by ischemia. The other part of the colon which are seen after splenic flexure are the descending colon and sigmoid colon, respectively. They are the other most common sites. So most of the time, 80 to 90%, it is commonly seen in the splenic flexure. So this is about colon. Sometimes the ischemia can also affect the small bowel along with the colon. So that is called as ischemic enterocolitis. That's of course a very rare scenario and seen in patients who have got a diffuse atherosclerotic disease involving the superior mesenteric and inferior mesenteric artery. So that has to be kept in mind. Coming to clinical features, ischemic colitis is commonly encountered in elderly females, and it's, as I explained earlier, it's related to the atherosclerosis, emboli, vasculitis, diabetes mellitus, chronic renal failure, autoimmune diseases, polycythemia, and patients who are on hemodialysis. So all these conditions and comorbidities, they predispose for the occurrence of ischemic colitis by either by decreased blood supply or by reducing the perfusion pressure and oxygen supply to the colon. So that's the pathophysiology related to these comorbidities. There is one more classification, what is called as Maston's classification, of ischemic colitis. There are three types based on this classification. One is the gangrenous type, that is because of ischemia of the full thickness colon, and it inevitably results in peritonitis. The second type is the stricturous type, where there is ischemia of the muscularis layer and causes fibrosis and ultimately scarring, resulting in stricture formation that results in chronic ischemic colitis or chronic ischemic colitis with stricture, and patients are prone to go for obstruction, producing a classical intestinal obstruction and its associated features. The third type in this classification is the transient type. This is because of the involvement of the most vulnerable layer, that is mucosa, and that results usually in sloughing out of the mucosa and bleeding, resulting in bleeding per rectum. It can be a mild or a severe form, but usually it recovers completely. So patient has to be kept under observation for the occurrence of any complications and monitoring. So that's about the Marston's classification. Coming to the clinical features, patients usually with the ischemic colitis usually present with sudden onset of crampy abdominal pain, usually of mild degree, associated sometimes associated with vomiting and abdominal distension, and it's usually localized to the lower left quadrant or the upper left quadrant. So it's associated with the passage of either bright red or maroon blood in the stool. And once the patients are assessed, they have to be admitted and examined serially for the evidence of peritonitis, fever, then elevation in the white blood cell count, and assessment for the worsening of symptoms. So patient has to be examined every second hourly and and a chart has to be maintained for the monitoring of all the vitals and the abdominal examination. So in case the patient is going into deterioration, he has to be immediately taken up for surgery, especially when there is association with peritonitis. Coming to the differential diagnosis, the commonest differential diagnosis as this ischemic colitis occurs in elderly people is the carcinoma colon, wherein there can be a bleeding per rectum and sometimes there can be associated pain due to obstruction. The second commonest differential diagnosis is the ulcerative colitis, as the symptoms mimic ischemic colitis in the form of bleeding per rectum and colicky pain. So this differentiation is very important because the ulcerative colitis patients need to be treated with steroids in acute phase and tackled for the symptoms, whereas in ischemic colitis, in acute phase, the steroids is not indicated, but they have to be observed for the deterioration of symptoms, and if deteriorates, taken up for surgery. The other important differential diagnoses are Crohn's disease and tuberculosis. Of course, the clinical symptoms and the examination findings vary in these two disorders. Coming to management, early and appropriate diagnosis of colonic ischemia depends on serial examination and evaluation by radiography or colonoscopic evaluation or both of the colon, as well as repeated clinical evaluation of the patient by monitoring his patient's vitals and per-abdominal examination. So a combination of radiography, colonoscopy and clinical findings may be necessary in all the patients before making up for further decisions. So moving on to the investigations, usually once we are suspecting colonic ischemia, a plain X-ray of the abdomen is taken. Usually there is because of mucosal edema and submucosal hemorrhage, there is what is called as thumb printing sign. So this classically seen in ischemic colitis. So thumb printing sign is seen in ischemic colitis. So many of the times we'll have to go ahead with the CT scan of the abdomen, especially when there is suspicion of other conditions. So the carcinoma or the ulcerative colitis. Then in such cases, CT scan will usually reveal a colonic wall thickening with increased due to increased enhancement of the wall, and there is associated posterior fat shadowing. So that is the CT scan. And ideally in acute stage, the colonoscopy or sigmoidoscopic examination, or for that matter barium enema, is not recommended, because we don't know the thickness of the ischemia and whether it has got any gangrene or compromised blood supply. So in order to avoid the risk of perforation, these procedures are not recommended. But in chronic stage, once the patient is stable and he has the symptoms have subsided, but he has got some mild discomfort or symptoms, in such cases colonoscopy and contrast study is a must in order to look into the inside of the colon and take a biopsy if required. The treatment, as I already explained, these patients are having associated other comorbid conditions and acute medical emergencies. So the treatment, majority of the patients will recover from conservative treatment by treating the other associated conditions. And from the abdomen part, the bowel has to be kept under rest by keeping patient nil by mouth, and start with fluids depending on patient condition. The fluids has to be titrated as per the need, and patient has to be started with antibiotics, preferably a broad spectrum antibiotics, and adequate perfusion has to be maintained in these patients, because if the ischemia is not tackled in the early phase, the chances of going for gangrene and perforation is very high. So adequate perfusion and the parameters to check for the perfusion, like the oxygen saturation, vitals monitoring, and urine output, all these things has to be monitored regularly, apart from starting the drugs. So suppose then what are the complications we'll encounter even with conservative management? Is patient can go in for gangrene and peritonitis, or he can land up with stricture, especially in chronic variety, and there can be segmental ischemia. So that segmental ischemia is where a part of the colon is will get ischemic and becomes obstructed. So in all these cases, surgery is indicated. So the commonly performed surgery is laparotomy and resection of the part which is gangrenous or ischemic. Most commonly, the splenic flexure is commonly involved, and splenic flexure has to be resected and followed by the anastomosis. And if the colon is highly precarious for ischemia again, so it's preferable to cover the anastomosis by doing a diversion, ileostomy or colostomy. In acute phase, where there is patient has got peritonitis, it's not recommended to do a resection and anastomosis, and in such cases a diversion colostomy is what is required. So coming to the benign tumors or polyp of the colon. So you all know that polyp is a mass arising from the mucosal surface, projecting into the bowel lumen beyond the epithelium. So that is what is the definition of polyp. It's a small protruding mass from the mucosal surface of an intestinal tract. It can be seen anywhere from the esophagus starting up to the anal canal. So these polyps, either they can be sessile or they can be pedunculated. So you know that sessile is the pedunculated is the one which has got a stack attached to the lining mucosa, and usually it is easy to manage. Whereas the sessile one is the one which doesn't have any stack, so it has got a broad base and it is difficult to remove. The classification, the polyps are usually classified into different types. The first one is the inflammatory. Inflammatory, we have four commonly seen varieties. That is the ulcerative colitis, inflammatory one seen in ulcerative colitis, or seen in segmental colitis, or it can be seen in Crohn's disease or in the diverticulitis. And the second type is hyperplastic or the metaplastic one, which is commonly seen in rectum. And the third variety is the Homotomatus Polyps. So these again has got three types: the Peutz-Jeghers syndrome, which is commonly encountered in the jejunum. Then we have juvenile polyp, and the third one is the bronchite Canada syndrome. So these three are commonly encountered with Homotomatus polyps. Then the next variety is the neoplastic polyps. So usually they are divided into three types: tubular, or villus, or tubulovillus. So usually tubular polyps are pedunculated and villus one are sessile ones. So we'll just discuss about the juvenile polyp and the Peutz-Jeghers syndrome, which is commonly seen in clinical practice. The juvenile polyps are commonly seen in childhood group and infants. So it's the commonest polyp of the colon and the rectum. The importance being it can cause the intersusception, and the polyps can prolapse through the rectum with associated bleeding per rectum. So parental examination is very important in this age group whenever they present with bleeding per rectum. Investigation wise, a colonoscopy is mandatory to look for the site of the polyp, the distribution of the polyps, and polypectomy is indicated if it is symptomatic and causing bleeding. It has to be kept in mind that the juvenile polyp is not a pre-malignant one, unlike the Peutz-Jeghers syndrome, which can turn into a malignant condition. So coming to the Peutz-Jeghers polyp, Peutz-Jeghers polyp its name.
Yogesh, Rajni class ಆಗೋಯ್ತಾ?
So Peutz-Jeghers polyp is commonly seen in small intestine, that is in the jejunum, but it can also occur in the colon as well. So the features are these polyps are multiple. They can have familial predisposition, and it's usually Homotomatus in nature. And the etiology for the occurrence of this polyp is because of the defect in the tumor suppressor gene, that is STK11, autosomal dominant disease with germline mutation in the gene. So it's usually associated with the melanosis of the oral mucosa, lips, and occasionally digits also. And microscopically, it has got a classical characteristic feature containing tree-like branching filaments of mucosa with smooth muscle wall. So this is a characteristic feature seen in the microscopic examination of the Peutz-Jeghers polyp. And it can occasionally turn into malignancy. So it's very important for the evaluation of these polyps and excision if they are seen. Coming to the adenoma of the colon, it's the commonest benign tumor in the large intestine. So it can, as I already told you, it is nothing but a neoplastic polyp. So it can be a tubular villus or tubulovillus histologically. The commonest one is the tubular adenoma, which constitutes around 70% of the polyps. The next in line being 25% by the tubulovillus and 5% by the villus polyps. And it also can be solitary or multiple, and it can be either sessile or pedunculated. So this is these are the characteristic features of adenomas. So the important feature about these villus tumors is that most of them are sessile tumors, and these usually secrete the mucus and the intestinal fluid from their surface, and that can cause diarrhea, mucus discharge, and occasionally if it is not diagnosed early, the patients can land up in hypokalemia, hypoalbuminemia, and other complications. So that's usually termed as WDHA syndrome. So coming to the what about the risk of malignancy in these adenomas? Yes, of course, there is possibility of occurrence of malignancy in these polyps. So the risk of malignancy depends on the size of the polyp and the nature and the microscopic features of the polyp. So coming to the size, if the size of the adenoma is more than 2 centimeter, the chances of developing carcinoma is high, around 30 to 50%. Whereas if the size is around 1 to 2 centimeter, it is just around 10%, and if it is less than 1 centimeter, it's less than 5% chances of carcinoma. So higher the size, the higher the chances of occurrence of or the turning into malignancy is high in these polyps. So if the polyp is sessile compared to a pedunculated one, the chances of malignancy is high. And as I already told you, villous polyps compared to tubulovillous and tubular polyps have got a higher predisposition. And suppose if we take biopsy from the polyp and if we find dysplasia, especially moderate and severe dysplasia, these polyps are more susceptible for the occurrence of malignancy. Hence, the polypectomy has to be complete. Coming to an important condition in polyps, which is usually asked as a question in your exams. So there is familial adenomatous polyposis, in short called as FAP. So this is associated with the occurrence of innumerable number of polyps all over the colon. Sometimes also associated with polyps in other organs also. So in this picture you can see that the whole of the large colon, I think this is a part of colon, this whole of the colon is studded with innumerable number of polyps, countless sometimes. So usually the term FAP is called when we see more than 100 polyps in a patient who has got familial predisposition. So you might have studied in your pathology books that is usually inherited as an autosomal dominant neoplastic condition, and the gene APC gene is situated in the short arm of the chromosome 5. It usually presents in younger age group, around 15 to 20 years, and incidence is equal in both males and females, and commonly involve the colon, but it can also occur in the stomach, duodenum, and small intestine. So it doesn't mean that if the colon is removed and a patient cannot have the polyps elsewhere. So it can occur in other sites as well. Especially the duodenal adenomas are known to turn into a duodenal malignancy. So as I already told, FAP is defined clinically by the presence of more than 100 colorectal polyps, and it can also be characterized by the occurrence of duodenal adenomas and multiple extraintestinal manifestations. So these are the extraintestinal manifestations seen in FAP. So either it can be a benign lesions or it can be malignant ones. So the benign lesions, the most commonly encountered lesion is the congenital hypertrophy of the retinal pigmented epithelium, that is CHRPE. So it is usually seen in 70 to 80% of these cases. So ophthalmological examination is very important in these patients. Then the other benign lesions are the epidermoid cyst, then the osteoma, which is commonly seen in Gardner Syndrome, and desmoid tumor is also seen, more commonly seen in females. Then there can be supernumerary teeth and adrenal gland adenoma. So all these are seen in varying association with familial adenomatous polyposis. And the malignant lesions are the commonly seen ones are the thyroid malignancy, seen in 2 to 3% of the patients. Then we have got a brain tumor, commonly the medulloblastoma, and in the liver we have got hepatoblastoma. So all these are extraintestinal features of the familial adenomatous polyposis. So over 80% of the cases have associated a positive family history. So that's why all the patients who are diagnosed with FAP, the family has to be screened for the presence of this gene, and it has to be screened for all the members and advised treatment if the polyps are found. And the remaining 20% of the patients, there need not be any positive family history, so there might be a new mutation, occurrence of new mutation in the APC gene that can result in the familial adenomatous polyposis. So as I already explained, it can be associated with the duodenal or ampullary carcinomas. And the two important syndromes which is commonly associated with this FAP is one is the Gardner syndrome, the other one is the Turcot syndrome. So Gardner syndrome is nothing but association of FAP with desmoid tumor in the abdomen and osteomas and epidermoid cyst, commonly the sebaceous cyst. So if you find a patient with who has got a polyps in the colon and associated epidermoid cyst and osteomas in the external survey of the patient, then most so the patient has got a Gardner syndrome. And if the patient has got features related to the CNS disorders, which can happen to be a brain tumor like medulloblastoma or gliomas, and if the patient has got polyps in the colon, it is called as Turcot syndrome. So these are the two syndromes commonly encountered with FAP. Usually in FAP, the number of polyps will minimum of 100 polyps will be there, and it can vary from even thousands or 10,000s. And sometimes in some patients, the number of polyps can be less than 100. When we do evaluate with colonoscopy, and if we find that the number of polyps has got is less than 100, then it is termed as attenuated FAP. That is a variety of FAP which is called as attenuated FAP, and it is usually because of the variation in the mutation of the other genes. So how does the patient present with FAP? Most commonly they present with with the lower abdominal pain or the blood and mucus through the per-rectally. And because of the secretions from the polyp, patient can have increased secretion in the colon and the small intestine, and they can have diarrhea. And because of the loss of proteins in the stools, patient will have hypoalbuminemia and protein loss, due to which patient can also have weight loss in that scenario. So how do we investigate such patients? Whenever we with history we come to a conclusion that patient might be having polyps, we want to confirm whether the patient has got a few polyps or he has got a polyp studded in his whole colon or there is associated polyps in other sites as well. And after thorough physical survey, patient and per abdomen and per rectal examination, patient has to be subjected for colonoscopy. So earlier they used to do what is called as double contrast barium enema. So in such cases, we used to find out the filling defects in the colon, and we used to confirm that patient might be having this thing. But the problem is that we were not able to take the biopsy in such cases. So the colonoscopy is the gold standard investigation for the diagnosis of the FAP, as it aids in taking the biopsy. But the conclusive diagnosis will be obtained only after the what is called as APC gene testing. So the patient has to be subjected for this gene testing for this adenomatous polyposis coli gene, and if the gene is positive, it is 100% sure that the patient has got FAP and he needs treatment in the form of surgery. And as I already mentioned, screening of all the members of the family is a must. So all the family members has to be screened for this mutation in this APC gene. Coming on to the treatment, so we have to remember one point here, that if the patient has got FAP and if it is proved, there is 100% chance that the patient will will develop colorectal cancer if surgical intervention is not done. So that has to be kept in mind. Even if one polyp even if there is one polyp and if it is because of APC mutation. So the treatment has to be aggressive and at the early stage, because these patients are usually between the 15 and 25 years of age. So they've got a quite long lifespan left. So any surgeon doesn't require them to go for a complication like colorectal cancer and end up with the cancer at an early stage. So these patients has to be treated as early as possible whenever the diagnosis is conclusive of FAP. Coming to the procedures which are commonly done, the commonly done procedures, see, as the FAP involves whole of the colon and rectum, the best modality of treatment, that is surgical treatment, is the proctocolectomy. That is removal of the rectum as well as the colon, and followed by, so once we remove the colon and the rectum, we are left with the small bowel and the part of the lower rectum or only anal canal. So such scenario, we'll have to anastomose the end of the ileum or the loop of the ileum as a pouch into the beginning of the anal canal. So that's called as Ileoenol Anastomosis. Usually done is the ileal pouch. So we'll create a pouch with the end of the ileum. I'll just show you the diagram. So here you can see that once we remove this whole of the colon and the rectum, preserving the anal sphincter. So here you can see that the ileum is made into a pouch. Sometimes we will have to do what is called as temporary ileostomy, because the risk of leak in this anastomosis is quite high in this pouch anal anastomosis. So we'll have to do a ileostomy which diverts the flow out of the anastomosis, and we can revert it back after the anastomosis has healed, probably after 3-4 weeks. So this is how an ileal pouch look. This is made from the end of the ileum. This is called as J pouch, which is commonly performed restoration. So that is ileal pouch anal anastomosis. So now this pouch, ileal pouch, acts as a reservoir and functions as a neorectum. So this, since the rectum has been removed, this functions as a new rectum. And these patients has to be kept under serial follow-up and yearly surveillance with upper GI endoscopy, as well as if required scopy through this pouch also. So we'll have to assess we'll have to look for the occurrence of polyps again. And whenever the patient presents with bleeding from the pouch, again it has to be kept in mind that the patient might be having a polyp elsewhere in the small bowel as well. And since the ileum is made into a neorectum, patient will have a lot of problems in adjustment of this neorectum, especially because this is not used to be a used to store the stools. So the body requires time for the adjustment or the acclimatization for this system. So patient can land up with leak in this anastomosis that can form the pelvic sepsis, pelvic abscess, and other complications. There can be a chronic inflammation in this pouch because of the change in the microflora, and that can cause either an acute or a chronic pouchitis, so which has to be treated with steroids and antibiotics as well as probiotics. So this is a little bit about the what is called as proctocolectomy with ileoenal pouch procedure. So the one more procedure which is done, suppose if we want to preserve the rectum and give at least some continence to the patient, in such scenario, and if there are no polyps in the rectum, we have an alternative, what is called as conservative colectomy with the anastomosis of ileum into the rectum. So we are not going to remove the rectum, but we are removing the whole colon up to the rectosigmoid junction, and followed by the anastomosis of the ileum to the rectum. But what has to be kept in mind is such patients has a propensity for the development of the polyps in the part of rectum which is left. So they need a regular follow-up with the scopy for the visualization of the rectal polyps, and if the polyps are found, they have to be removed immediately, or sometimes if the polyps are more, the patient might require a completion proctectomy as well. So that's why the restorative proctocolectomy with ileoenol anastomosis in 2 stage is that's why it is recommended as a standard procedure. So this is the diagram where it's depicting the picture showing where we are removing the whole of the colon. The large bowel is whole of the large intestine is removed, and we are preserving the rectum here. Then we are going to anastomose this end of the ileum into the rectum. So this is the ileorectal anastomosis. So this is the side to end anastomosis of ileum and the rectum. So the advantage of
बिस्किट खाना है? अंडा तो खाना ही होगा। क्या हुआ?
Can someone use their mics? Someone is
कभी-कभी तो कचरे के डब्बे में मुंह भी डाल देता हूँ। आप कभी गुस्से में आकर मेरे खाने में बॉल डाल के तो नहीं खिला दोगी ना?
okay. That's the treatment of the FAP. So we have to remember that these patients has to be kept under regular follow-up for by upper GI endoscopy, and as and when the patient is symptomatic, the other investigations. So with this, I'll conclude the topic for today's discussion. So I thank everyone, and any questions from the students are invited.
Questions? Last is a question you type ಮಾಡಿಲ್ಲ.
Okay. Download ಆಗಿಲ್ಲ.
ಆಗಿಲ್ಲ.